Okay, picture this. You're petting your dog, your cat, everything seems fine, and then you notice maybe a small cut or just a bump, but it's bleeding a lot, like way more than you'd expect.
Yeah, or maybe a nosebleed that just won't quit. It's definitely worrying when you see that.
Right, and your first thought is probably, okay, something's wrong with clotting.
Makes sense. And often people jump to thinking about a low platelet count, thrombocytopenia. That's a really common reason for bleeding problems.
And it often is. But this is where our deep dive today gets really specific. What if the vet checks the platelet count and it's normal? Or maybe just a bit low, but the bleeding still seems way out of proportion.
Ah, that's when we start thinking about something called thrombocytopathy.
Thrombocytopathy,
Yeah,
okay.
it's where the number of platelets is okay, more or less, but the platelets themselves aren't working right. Their function is off.
So they're not doing their job.
Exactly. It messes up what we call primary hemostasis, that crucial first step where platelets are supposed to rush in, stick together, and form a plug to stop bleeding from a damaged vessel. If they can't do that properly, the bleeding doesn't stop like it should.
And we've got some really good source materials to walk us through this clinical guides on these thrombocytopathies in dogs and cats. So our mission today is to kind of sift through these, pull out the key info, the surprising bits, the practical takeaways.
And really understand what's happening when those platelets are physically present but, functionally failing. We'll look at what it looks like, why it happens, how it's diagnosed, and what can actually be done.
Okay, let's unpack it. So the heart of the matter, the core issue with thrombocytopathy is platelet dysfunction. They're there, maybe plenty of them, but they're just not performing their duties.
That's the essence of it. And because they can't form that initial plug effectively, you might see spontaneous bleeding or bleeding that's just excessive after even really minor injuries.
And the sources say mucosal bleeding is common.
Very common. Bleeding from surfaces like the gums, the nose, maybe the lining of the gut or urinary tract, that's often the first sign you'll notice.
And just to circle back to that earlier point, if a pet has both problems, like low platelets and the ones they have don't work.
Oh, yeah, that's a double whammy. The bleeding will be much, much worse than you'd expect just from the low count alone. It really compounds the problem.
Okay, so to get why they might be failing, maybe a quick refresher on what healthy platelets should be doing.
Good idea. Think of them as the first responders to a blood vessel injury.
Right. So vessel gets damaged, exposes stuff like collagen.
Exactly. And platelets are drawn right there. Job one is adhesion, sticking to that damaged spot. And they get help from a protein called von Willebrand factor, or VWF. It's like a molecular Velcro.
Velcro, I like that. Okay, so they stick. Then what?
Then they get activated. They change shape, become stickier, and crucially, they release chemicals stored inside them in little packets called granules.
Chemicals like...
Things like ADP, thromboxane A2, TXA2, serotonin. These are signals that basically shout, help! They call in more platelets and also tell the blood vessel to constrict to try and slow down the blood flow.
Makes sense. Amplifying the response.
Right. And the third main job is aggregation. All these activated platelets start clumping together. They use special receptors on their surface. A key one is GPI-BI-IA to link up, using fibrinogen like a net between them. This forms the primary platelet plug. It's the initial temporary fix.
The first Band-Aid, essentially.
Pretty much. So thrombocytopathy means there's a breakdown somewhere in that chain. Adhesion, activation, and secretion or aggregation. One or more steps aren't working right.
Got it. And the sources break these down into two main categories, right?
Correct. You've got the inherited kind, the ones the animal is born with due to a genetic defect. And then you have acquired thrombocytopathies, which develop later on because of something else.
And you mentioned the acquired ones are actually more common.
Generally, yes, in dogs and cats, but the inherited ones, while rarer, are often really interesting because they can be quite specific to certain breeds, pointing to particular genetic glitches.
Okay, let's dig into those inherited ones first then. Sounds like they might show up early.
They can, yeah. Sometimes owners notice unusual bleeding when a puppy or kitten loses its baby teeth. But really, they can be diagnosed at any age, maybe after a minor surgery or injury triggers more bleeding than expected.
And there are different ways these inherited defects can manifest.
Oh, absolutely. Some are problems with those platelet receptors we talked about. A well-known example is Glanzmann's thrombasthenia.
Glanzmann's, okay.
Here, the issue is with that GPI-BI receptor, the one needed for platelets to aggregate, to clump together. If that doesn't work, aggregation fails, and you get pretty severe bleeding. Breeds like Great Pyrenees, Otter Hounds, Old English Sheepdogs are known to get this.
And there's one specific to Basset Hounds.
Yes, Basset Hound thrombopathy. One of the sources notes this is a problem with the internal signaling within the platelet due to a specific gene mutation called G5, I think it was called. It affects GPII by I function and other receptors, so both clumping and spreading are impaired. Also seen in Spitz breeds and Landseers, apparently.
Interesting. What else?
Well, there's canine thrombocythemia linked to something called cyclic neutropenia in gray collies. That one affects a different receptor complex, GPIIXV, which is needed for that initial adhesion to VWF, the sticking to the wall part. And another source mentioned a specific mutation in the P2Y12 receptor. That's an ADP receptor found in greater Swiss mountain dogs. ADP is one of those key activation signals.
So problems sticking to the wall, sticking to each other, or even hearing the call for activation. What about problems sending the signals, releasing those factors from granules?
Right, those are the platelet secretion or storage pool defects. The platelets might stick okay, maybe even clump a bit, but they don't release enough of the chemicals needed to really rev up the process and build a solid plug.
Chiari-Akigashi syndrome, or CHS, comes up here.
It does. That's actually a broader genetic issue affecting storage granules in many cell types, not just platelets. You see it in Persian cats, some Burman cats, certain dog breeds. Often causes a milder bleeding tendency. Vets might spot characteristic giant granules in cells on a blood smear, and sometimes the coat color is diluted too.
And other storage issues.
Yeah, there's also a more specific platelet-dense granule deficiency where storing or releasing ADP and serotonin is the problem. Seen in poodles, sometimes with large platelets and sharp eyes. Bleeding can be variable. One source also flags a delta granule deficiency specifically in American Cocker Spaniels.
Then there's Scott syndrome in German Shepherds. That sounds a bit different, a procoagulant deficiency.
It is slightly different. The initial plug might form okay, but the problem happens next. Activated platelets are supposed to flip a specific molecule, phosphatidylserine, to their outer surface. This surface is essential for the later clotting factors to assemble and build the strong fibrin mesh that stabilizes the plug. In Scott syndrome, they fail to do this flipping effectively.
So the reinforcement stage fails.
Pretty much. The initial patch is there, but it doesn't get properly secured. And one source specifically mentions that unexpected bleeding after surgery is a common way this shows up.
Okay, and we absolutely have to talk about von Willebrand's disease, VWD, here. It sounds like it mimics these problems.
Yes, it's a crucial one to differentiate. With VWD, the platelets themselves are actually fine. They work normally. The defect is in the von Willebrand factor, that VWF Velcro protein we mentioned.
Ah, the glue itself is faulty.
Exactly. Either there isn't enough of it, or the VWF that's there doesn't function properly. Since VWF is essential for that very first step, platelet adhesion, a problem with VWF causes signs that look exactly like a platelet function defect.
So you'd see prolonged bleeding, a prolonged bleeding time test.
Right. Same initial signs, same screening test result, but a totally different cause, faulty glue, not faulty platelets. Distinguishing them is key for management.
And VWD is pretty common, right?
Quite common, yeah. Affects many breeds. Dobermans, Goldens, German Shepherds, Shelties, lots of others. And there are different types depending on how severe the VWF issue is.
Okay, those inherited ones are definitely complex, often tied to specific breeds. Let's switch gears now to the acquired thrombocytopathies, the ones pets develop later in life.
Right, and these are generally more common. They happen secondary to something else going on. And a really, really big category here is drug-induced problems.
And top of that list seems to be NSAID's non-steroidal anti-inflammatory drugs.
Absolutely critical for owners to know this. NSAIDs, especially aspirin, interfere with platelet function. They block an enzyme called HEOX1, which platelets need to make thromboxane A2, TXA2.
Yeah.
And TXA2 is vital for aggregation and telling blood vessels to constrict.
So even one dose can cause issues.
With aspirin, yes. The effect can last for the entire lifespan of the platelets exposed to it, which is days. The sources do note that the newer, more HEOX2 selective NSAIDs generally have much less or even no significant effect on platelet function, which is good. But aspirin is a major one to watch out for.
Are there other drugs implicated?
Yes, things like high doses of certain antibiotics, some penicillins, cephalosporins. One source mentions that in people, drugs like tetracyclines, certain anesthetics, even antihistamines can sometimes cause issues, though it notes the documentation might be less robust for all of these, specifically in dogs and cats. Some anticoagulants rarely. Anesthetics can sometimes cause temporary changes during a procedure.
And then, interestingly, some drugs are meant to inhibit platelets.
Exactly. Like clopidogrel, you might know the human brand name Plavix. Vets use it therapeutically sometimes, like for cats at risk of blood clots in their aorta or dogs with pulmonary hypertension. The whole point is to make platelets less sticky to prevent dangerous clots. It just shows how many things can mess with platelet function.
One source also added potentiated sulfonamides like TMPS and those hydroxyethyl starch fluids sometimes used for shock,
Right. And beyond drugs, various systemic diseases can hammer platelet function.
like kidney failure or uremia.
Yeah. When kidneys fail, waste products build up. Some of these toxins, like guanidinosuccinic acid, directly interfere with platelet adhesion and aggregation.
Severe liver disease, too.
Definitely. The liver makes most clotting factors, but severe liver disease can also lead to circulating inhibitors that mess with platelet aggregation. Things like bile duct obstruction, cholestasis, or liver shunts can also be involved.
And having too much protein in the blood.
Hyperglobulinemia.
Uh-huh. If you have really high levels of certain proteins, like with multiple myeloma, these proteins can literally coat the platelets and physically get in the way of them sticking together properly.
Okay, what about DIC, disseminated intravascular coagulation? That always sounds really bad.
It is. It's a catastrophic system-wide activation of clotting that paradoxically leads to both widespread tiny clots and severe bleeding. It chews through platelets and clotting factors like crazy, and the inflammation and circulating breakdown products also make the remaining platelets dysfunctional. It's a terrible combination.
Wow. The sources listed quite a few others, too. Yeah, things like severe anemia, sometimes just due to dilution, SIRS, or sepsis. That massive systemic inflammation can activate platelets initially, but then lead to exhaustion or dysfunction. Certain blood cancers, myeloproliferative disorders, where the bone marrow produces abnormal platelets, direct damage from heat stroke, even snake bites, particularly from pit vipers, where the venom can directly mess with platelets or cause them to be consumed.
And infectious diseases like ehrlichiosis, leishmaniasis, immune-mediated thrombocytopenia, if it also targets function, heart disease, various cancers. It's a long list.
It really highlights how platelet function can be affected by so many other health problems.
Okay, so we've got a handle on the why inherited issues, drugs, diseases. Now, let's focus on the what. If you suspect this is going on, maybe bleeding signs, but a decent platelet count, what does that bleeding actually look like?
You're looking for signs typical of a primary hemostasis problem failure of that initial platelet plug.
Yeah.
And as we said, mucosal hemorrhage is really the hallmark.
Like those tiny red spots.
Exactly. Petechiae. Pinpoint, non-blanching red spots. You often see them on the gums, inside the eyelids, the conjunctiva, inside the ears, or on the sparsely haired skin of the belly. That's a classic sign.
And bigger bruises?
Ecchymosis, yeah. Larger, flat areas of bruising. Other key signs are epistaxis nosebleeds. Gingival bleeding from the gums, maybe spontaneously or just when chewing.
Blood in the stool or urine.
Right. Melena is the term for those black, tarry stools, which means digested blood from high up in the GI tract. And hematuria is blood in the urine. You might also see hyphema, which is blood pooling in the front part of the eye.
And a really crucial sign is prolonged bleeding, right, after something minor.
Absolutely. Bleeding that just goes on too long after a blood draw or a small cut or surgery. And one source made a great point. Sometimes the bleeding might stop initially, but then starts up again hours later. That delayed rebleeding is very suggestive of a primary defect like thrombocytopathy or VWD because the initial plug wasn't stable. And remember, Scott syndrome often shows up as postoperative bleeding.
Any less obvious signs?
Maybe. If there's bleeding into joints or muscles, you might just see lameness or swelling. And of course, if the blood loss is significant or ongoing, you'll see signs of anemia, weakness, lethargy, pale gums.
Okay, so we see these signs. The platelet count isn't drastically low. How do vets actually diagnose dysfunction and figure out the cause? It sounds like a puzzle.
It definitely can be. Bleeding plus adequate platelets, investigate function. That's the mantra. It starts with a really thorough approach.
History and physical exam first, always.
Crucial, you need all the details from the owner, what kind of bleeding, how often, how bad, what triggers it, any medications at all, especially over-the-counter stuff, any toxin exposure, any family history. And the physical exam is to confirm the bleeding signs and look for clues of any underlying disease.
Then the initial lab work.
Right. Start with a complete blood count, CBC. This confirms the platelet count is normal or near normal, usually looking for something over 100,000 per microliter as a rough guide in this context. But remember that nuance from one source. Some inherited types can have lower counts or weird-looking giant platelets. The CBC also tells you about anemia.
And the key in-clinic test for this specific problem.
the Buccal mucosal bleeding time, or BMBT. It's the most useful practical test for primary hemostasis. You make a tiny standardized cut on the inside of the lip or cheek and time precisely how long it takes to stop bleeding.
And normal is roughly under 4 or 5 minutes in dogs, maybe 2 or 3 in cats. The sources varied slightly.
Yeah, there's slight variation. Labs might have their own normals. But the key is that a significantly prolonged BMBT, longer than the reference range, points strongly towards a primary hemostatic defect, either platelet dysfunction or VWD.
What about the standard clotting tests, BT and APT?
Usually they'll be normal in uncomplicated thrombocytopathy. Those tests measure the later stages, the clotting factor cascade, secondary hemostasis. They'd only likely be abnormal if something like DIC was going on, affecting both systems. One source also mentioned thromboelastography, TEG, which gives a more global picture of clot strength. Fibrinogen levels are also usually normal.
Okay, so prolonged BMBT, normal platelet count, normal PT-TAP-PT, strongly suggests platelet dysfunction or VWD. How do you tell which or specify the platelet problem?
That requires more specialized testing, usually sent out to specific labs. Platelet aggregometry is a key one. It directly tests how well the patient's platelets clump together when you add different chemicals that should activate them. It's often the gold standard for diagnosing many inherited types.
And flow cytometry.
That can measure specific things on the platelet surface. For instance, you can use it to look for the number of GPI by II receptors to help diagnose Glanzmann's. And absolutely essential if the BMBT is prolonged is to run a von Willebrand factor antigen assay, VWF-G. You have to measure the VWF level to rule out or confirm VWD. One source also mentioned the Platelet Function Analyzer 100 as another screening tool for VWD suspects. And testing platelet factor 3 availability might be done for suspected Scott syndrome.
And if you suspect an acquired cause.
Then the investigation focuses on finding that underlying problem. Meticulous review of all drugs, comprehensive blood chemistry and urinalysis for organ function, maybe protein electrophoresis if you suspect high globulins, tests for infectious diseases, tracking down the root cause.
And for some inherited types, genetic testing might be an option.
Yes, for certain specific inherited disorders, genetic tests are available. They can confirm the diagnosis and also identify carriers, which is important for breeding programs.
Okay, we've navigated the diagnosis. Let's talk treatment. How do you manage these cases? Stop the bleeding, fix the cause.
It's multifaceted. You need to manage any immediate acute bleeding, you need to treat the underlying cause if it's an acquired form, and you need to provide ongoing support and prevention.
For active bleeding.
First, local measures. Direct pressure if possible. Systemically, the ideal way to provide working platelets is with blood products. Platelet-rich plasma, PRP, or platelet concentrates, deliver the most functional platelets per volume, but they can be hard to come by.
So often it's fresh whole blood.
Very often, yes. It provides functional platelets plus clotting factors and red cells if there's anemia. It's frequently the most practical and available option. Fresh frozen plasma, FFP, has factors but no working platelets, so it's not the primary treatment for just platelet dysfunction, though it might be used if DIC is involved. One source gave dosing guidelines like 1 unit of concentrate per 10 kilograms and suggested saving packed red cells or whole blood for significant anemia, maybe below 15% HDT.
Any drugs to help stabilize clots?
Yes, the antifibrinolytic agents, aminocaproic acid, EACA, or tranexamic acid, TXA. They help stop clots from breaking down too quickly, which can be really helpful, especially with that mucosal bleeding. Vincristine is mainly for boosting platelet numbers in immune-mediated cases. Its role in just fixing function is limited, though it can trigger platelet release in dogs.
And locally.
Things like gelatin sponges, cellulose, fibrin glue applied right to the bleeding spot can help. And a practical tip from one source: during active bleeding, restrict activity and be careful not to overload with IV fluids, which could dilute things.
What about desmopressin, DDAVP? We hear about it for VWD.
Right, it helps release stored VWF, so it's used in some VWD cases. The dose is typically around 1 microgram per kilo. SC or IV effect lasts a couple of hours. But interestingly, one source noted it can also improve bleeding time in dogs with platelet dysfunction caused by aspirin or liver disease. It helps in many human thrombocytopathies, so maybe worth considering in dogs too. The dose mentioned there was a bit higher, 3 micrograms per kilo SC. And that source had the neat idea of giving DDAVP to a blood donor before collection to potentially boost the VWF or platelet support for the recipient.
That is interesting. So, for acquired cases, treating the underlying cause is paramount.
Absolutely non-negotiable. If it's drug-induced, stopping the drug is often curative. If it's kidney failure, liver disease, sepsis, DIC, aggressive treatment of that primary condition is essential for platelet function to improve.
And long term, what do owners need to do?
Education, education, education. Owners have to know which drugs to avoid, especially human NSAIDs like aspirin, ibuprofen, naproxen. Give them a clear list. They need to minimize trauma, protect the pet.
And for the inherited types.
Genetic counseling is key. Affected animals and often carriers should not be bred. Owners need to understand it's likely a lifelong condition. And for any planned surgeries, as one source stressed, either avoid them or be fully prepared with blood products and extra precautions.
Are steroids used?
Generally, no, not for pure platelet dysfunction, therefore immune-mediated low counts. The only time might be if there's an immune component also affecting function, or maybe for transfusion reactions.
So, bottom line, the prognosis. What's the outlook?
It varies hugely. Really depends on the cause.
Good for drug-induced if caught early.
Often, yes. Stop the drug, function returns, outlook is good. But for inherited forms needing lifelong care, or acquired forms due to really severe underlying diseases like end-stage kidney failure or aggressive DIC, the prognosis is much more guarded.
And severe bleeding is always a risk.
Acute severe bleeds can definitely be life-threatening if not managed rapidly. Although one source did mention that while chronic or recurring bleeds happen with inherited types, fatal episodes are, thankfully, relatively uncommon.
Owner education seems like the absolute cornerstone here.
It's everything. Owners need to be partners, teach them exactly what bleeding signs to watch for petechiae, bruises, nosebleeds, blood and urine stool. Hammer home that severe or ongoing bleeding is an emergency.
Give them that do not give drug list.
Absolutely. Make it crystal clear, especially about human vets. Explain that diagnosis and treatment depend on finding the why. Be upfront about the genetics for inherited types, the no breeding recommendation, the lifelong aspect. Give a realistic prognosis, and be transparent about potential costs for diagnostics and crisis management.
Wow. Okay, that was definitely a deep dive. So summarizing, thrombocytopathies, bleeding disorders, where platelets are present but just don't work right, messing up that critical first clotting step. Finding out why takes a systematic approach, history, exam, BMBT, and often specialized tests like aggregometry or VWF assays.
Exactly. And it highlights that for really tricky cases, referral to an internal medicine or critical care specialist can be incredibly valuable for nailing down the diagnosis and the best management plan.
It really makes you stop and think about how incredibly complex these basic body systems are, like stopping bleeding, and how something that seems simple, like giving a common pain reliever or an underlying issue like kidney disease, can have such profound hidden effects on something microscopic like a platelet.
Absolutely. It kind of makes you wonder what other everyday things or subtle health changes might be impacting our pets in ways we haven't fully appreciated yet.